Now we come to the part of the conference where we give everybody $1,000 who stayed. No. Just kidding. It's my pleasure to introduce Mr. Chris Bailey, Senior Vice President with the Virginia Hospital and Healthcare Association. He's been with the VHHA since 1994. His overall responsibility for financial policy issues, health data programs, their strategic planning efforts, and their internal financial affairs. So please welcome Chris.
Good afternoon. How is everybody? Is now relative to its peers around the country on broad health and healthcare performance. Secondly, give you a flavor for what the community of hospitals and health systems in the Commonwealth are about in terms of improvement and what we've set for ourselves collectively for performance improvement. And then lastly, give you a sense of our perspective on the 800-pound gorilla that is healthcare reform up in Congress. So those three topics, and promise to get you out of here before 5 o'clock. Interrupt any time with questions or comments as we go along. We start off with the recognition that Virginia has many blessings. Virginia is a top-tier state when it comes to the strength of its economy, its attractiveness to the business community, its higher education system. My daughter walked the lawn in Charlottesville on Sunday. I'm a very happy camper when it comes to as a customer for the higher education system. She did spend a little time first thing that morning in a bar, but that's a different story. That's part of the tradition at Virginia. So a top-tier state. We are used to performing extraordinarily well. In healthcare, we have a lot of things to be thankful for, but I think we have room for improvement in terms of population health and the health delivery system. Other speakers have touched on the challenges facing us as a society. I just want to note that chronic illness, the costs of care associated with chronic illness, can and should be, I think, the focus for both performance improvement and cost improvement. The prior panel spoke to a very promising model for doing a much better job at managing chronic disease care for patients. That is where the spending is. We have our own 80-20 rule in healthcare. 20% of the patients represent 75-80% of the spending. All those patients have one or more chronic illnesses. And one thing we don't do extraordinarily well in the U.S. healthcare system is the coordination of care for those very complicated conditions. In Virginia, nearly a quarter of the population is obese. We're the 17th highest state in terms of obesity-related costs, 17th highest in infant mortality rate. That is not where the Commonwealth of Virginia can or should be. So health definitely has to improve as a society. We've got to bend those curves on chronic disease. And it takes strategies such as these. And a lot of folks have spoke to these, and there's a tremendous work going on nationally and in the Commonwealth. It's everyone's job to make improvement here. Healthcare, we have many strengths too. We are the world's R&D shop when it comes to healthcare. We invent and deploy more technologies in healthcare than any society in the world. I think Americans will always value innovation and development of new technologies. This will always be a distinguishing feature of the American delivery system. But it is also true that those technologies are not always deployed in the most effective fashion. So how do we restructure the incentives to make sure we're applying technology in the right place at the right time? And we accept the notion that we need to do much more to demonstrate improved value. It's a little hard to read. It's the healthcare policy wonk's favorite slide, but I just want to note the relationship between quality and cost is, and all the speakers have touched on this, but this is an important point. People talk about healthcare reform as trying to find the optimum balance among three competing priorities: quality, access, and cost. The evidence is abundantly clear that we can tackle both quality and cost simultaneously. If we do a better job on quality, we every single time do a better job on costs. The vertical axis here is how consistently care provided to Medicare recipients met the recommended course for treatment. So was a diabetic getting their hemoglobin A1C test with the right frequency as an example. Horizontal axis, spending. 2 lessons from this research. Tremendous variation on both dimensions. Look at the cost variation. This is Medicare patients, similar population, similar benefit structure, from a little less than $4,000 per person per year in Hawaii to over $8,000 in Louisiana. And look at and the other point is the tremendous relationship between those two. Those states who do better on quality end up doing better on cost. Virginia is in the right end of the distribution, but still not a top-tier state. In this case, it's in the upper left end of the distribution, but in the place we want to be, but not a top-tier state. This map shows a different take on quality differences among the states. This encompasses the entire population, not just Medicare. So if you have a high proportion of your population that's uninsured, you will tend to perform less well on this particular measure of performance. Virginia is a second-tier state in that lighter blue shade on overall healthcare quality delivery for the entire population. Note a bit of a north-south skew. There's something about freezing one's rear end off 3 months of the year that apparently is health-inducing. I've heard people shout out all sorts of different theories for why this might be the case. My own personal favorite is the schnapps. Apparently schnapps is good for you. But again, same message from the prior slide. Tremendous variation across the country in broad health system performance and healthcare quality. No state does extraordinarily well in every dimension of performance. Every state has opportunity for improvement. Virginia, again, a top-tier performer on economy and education, quality of life, lots of other dimensions, shouldn't be light blue. We should be white in this particular slide. And that's the vision, that's the set of strategies we've put together, is to elevate healthcare system performance and population health for the Commonwealth. This is spending per Medicare enrollee, and the only reason to show this slide is a lot of the debate you hear in Washington right now is trying to improve efficiencies, lower unwarranted variation, save money. In some of the strategies, they're suggesting they will provide penalties, that is disincentives, lower rates of payment to regions, providers, states that have high costs and low quality, and provide more support, more incentives for states that have high quality and low costs. The message from these facts is that Virginia has nothing to fear from that sort of incentive structure. We are a relatively low cost delivery system. This is for a Medicare patient, but it holds true for other populations as well. It's not to say we don't have room for improvement. We have lots of room for improvement, but we are, relative to other states, we are not Long Island, we are not Miami when it comes to the overall cost of healthcare delivery. We're a relatively efficient system, relatively lean in terms of the supply of hospital beds and healthcare services. So that's the good news from this comparison. Our pillar has, or our framework has 6 pillars. I'm only going to touch on 2 of them, and then we'll jump to the health reform discussion and talk about how we can elevate performance in the state. First, on higher quality, these set of goals and related strategies are things that we've talked about today that I think are very good. The VBCH, the effort that's part of VBCH, that's represented by all the speakers today, I think is evidence that there's tremendous energy around these sorts of strategies in the Commonwealth. That's something we should be thankful for. Something that hasn't been touched on, but I think will get more attention, is these expanded options for end-of-life care. It's an area, it's a sensitive area, but it's an area that Senator Warner, for one, wants to have a more vigorous discussion of and more best practices. How do we measure higher quality? One thing we've done with this framework is put some metrics on the table, not just aspirational goals, but how are we going to chart performance? How are we doing today? Where do we want to get to 3 to 5 years from now? On quality, the Virginia rate score here is from 2008 and most recently 2009. The target is not a hypothetical ideal level of performance. The target here is the average experience in the top 5 performing states in each of these areas. And again, our going in assumption, our going in belief, our going in value is that Virginia should be, could be, will be a top tier performer on these sorts of measures. So if you look at higher quality here, it's percentage of hospitalized patients getting the recommended care for heart attack, congestive heart failure, and pneumonia. It's an aggregation of the process scores related to those conditions in hospital compare. The gap was 89.3 is the average in Virginia in 2008, 92.4 in the target, and we've narrowed that. We've improved, but so have the target states. So we're making the right progress, but not as quickly as we need to become in that top tier. The second one, percent of surgical patients getting the appropriate onset and cessation of antibiotics around a procedure. Again, we've improved. The top 5 states have not improved too much, so we're closing the gap there. This is after 1 year. We intend on getting there within 3, if not sooner. This third one, percent of high-risk nursing home patients with pressure sores, is not a point of performance about which Virginia can or should be proud. We have a very high rate of high-risk nursing home patients, that is, long-stay nursing home patients who develop pressure sores. 13% of the time. It's better than the almost 16% last year, so we're moving in the right direction, but still high, nearly double the rate you find in the top 5 performing states. Not good enough for the Commonwealth of Virginia. There is a policy dimension to that. We have an extraordinarily lean Medicaid program. We don't pay nursing homes terribly much. We have pretty low rates of activities of daily living that you have to reach before you can qualify for nursing home admission. We pay our nurse aides pretty poorly. It's tough work. There's a lot of turnover. And guess what? Nursing homes with high rates of turnover are often nursing homes who tend to perform less well on this particular score. So that there's something the state may need to do to elevate performance here, but there's a lot the delivery system can and should do as well. One note on efficiency. This is the way we look at efficiency is different. It's avoiding unnecessary care where possible. We do have high rates of admission to hospitals in Virginia for ambulatory care sensitive conditions. This is for Medicare population and insured population. Extraordinarily high level of admission to hospitals for those conditions relative to the top 5 performing states. People are ending up in the hospital, a Medicare insured patient, for conditions that can and should be managed on an outpatient basis much more frequently in Virginia than they are in the top 5 performing states. That's poor quality, that's inefficient care. We need to address that as a community of practitioners. This is the whole scorecard. So in every case, 22 measures. Where are we now? What are the top 5 states doing this particular measure? And what can we do to close the gap? That's our framework. And we're making progress 1 year in, but let's see where we are 2 or 3 years from now. Now, there's a bit of a debate going on in Washington on health reform, you may have heard. People who spending time on this topic describe the nature of the debate up there as fluid, which is lobbyists speak for they have no earthly idea what's going to happen in 3 to 6 months. In the midst of that sort of chaos, I think it's important to get a grounding. What do we know? What are the certainties about what's happening to the delivery system that relate to the health reform debate? And I think Rich Umdenstock at the American Hospital Association did a nice job capturing these a couple of weeks ago. We know the delivery system will be more integrated. That's hospitals and physicians working together as more effective teams, often under the same organizational umbrella. Lots of variation in the structure and form for that integration, but it is happening everywhere. Big system, small system, Eastern Shore, Southwest Virginia, South Side Virginia, where I was last week, Northern Virginia here. We are, and we're becoming more integrated as a delivery system. And there's lots more IT support to tie together the various pieces of the system than there used to be. And a fair amount of money in the stimulus package to incentivize further deployment of those IT tools. IT EMR systems are just a means to an end. It's better performance as a delivery system that is the end we're seeking. So number one, we know we're going to be more integrated. Hopefully that means we can survive under a more bundled form of payment, a more at-risk form of payment. But we also know we'll be more at risk as providers, as delivery systems. More at risk for, that is, our income more closely tied to quality, avoiding unnecessary care, and performing on safety. People are beginning to, once again, if you're in this business long enough, things do come around. And about 9 or 10, 12 years ago, capitation to organized delivery systems was the strategy du jour. It tended to fade away, except in a few cases, and now it seems to be coming back. Finding a way to provide the right incentives for a delivery system to take care of a population. Capitation is one approach, but there are lots of intermediary steps, and I'm quite certain we're going to be moving down those, both from the federal level and hopefully at the grassroots level from business coalitions and other groups. Fixing the incentives are absolutely critical to accelerating performance improvement, and nobody can be more effective at that than combinations of purchasers. And finally, we know we're going to be more accountable for safety, for quality, for community benefits as employers and as large economic entities in our communities. These are our criteria for how to evaluate whether health reform is successful or not. Will it be bipartisan? Will it allow for long-term views on savings, or will it focus more on just short-term cuts? Are we going to have a balanced approach to expanding coverage? Will it be shared responsibility for financing? Don't forget about the simple stuff about administrative simplification and tort reform that can take unnecessary costs out of the system. These are the things we're emphasizing currently. I've already spoken to the delivery system reform, and the Senate finance package has a fascinating list of options. They've thrown everything on the table, much of it quite aggressive. Our own next steps, with or without health reform, are these three. Undertaking a quality and safety initiative, again, top-tier performance on hospital quality, safety, focusing on healthcare or hospital-acquired infections as the first priority. It's public reporting around central line-associated bloodstream infections, and we're pursuing a partnership with our colleagues at the QIO and the Medical Society to have a collaborative around healthcare-acquired infections that will apply more broadly than just CLABSIs. We'll be pursuing designation as a patient safety organization and supporting a whole lot of quality and safety improvement work to try to demonstrate to our communities that we are a top-tier performer when it comes to avoiding unnecessary harm as a community of providers. This week, maybe next, we'll be announcing a collaborative with the health plans on taking some unnecessary administrative costs out of the system. There's something like 15 cents of every healthcare dollar goes towards administrative costs. I call that waste. Other people call it their jobs. But we have, together, health systems, health plans, and the Commonwealth of Virginia identified some priorities and have chosen an IT partner to take a lot of the administrative costs out of the administrative data exchange and get an efficiency for the plans, the purchasers, and the providers at the same time. It's unusual for health systems and health plans to get together around the same table and not have food thrown at each other. So I think it's notable that we've reached an agreement here on a common business interest. And again, we hope to have an announcement in the next week of our of our initiative along those lines. Secretary Chopra, when he was here in Virginia, was a key part of getting that done. He's now moved on to become or nominated at least to be the Chief Technology Officer for the U.S. And then finally, this public-private partnership for health and healthcare excellence. We've engaged in conversation with a number of business groups about how to support measurement and incentives around chronic disease care. And we hope that, too, probably after the health reform dust settles, we hope that, too, accelerates here in Virginia. We think there's a lot that can be done in collaboration with our purchaser partners to measure and accelerate improvement, especially around chronic disease care, where most of the spending occurs. On HAIs, healthcare-acquired infections, you all have seen lots of evidence of success. There is tremendous progress being made in the Commonwealth. This is one example of a 74% reduction in 4 years on nosocomial infection rates in one Virginia health system, and a similar reduction on CLABSIs and ventilator-associated pneumonias. St. Terry Williamsburg Community Hospital is one example, just celebrated its 5th year anniversary without having any ventilator-associated pneumonia case. So thank you for everything you do and for making this improvement and helping Virginia get to its rightful place, a top-tier performance on health and health care. I'd be happy to answer any questions anybody has. See that? Just under 5 o'clock. Yes, sir.
I'd just like to know what impact the uninsured have in Virginia in terms of our board and also in terms of the finances of a hospital-related emergency room. How much of that loss, really, in revenue is passed on to other folks?
The way we count it, the costs of uncompensated care, net of all related subsidies, so this is a fully net figure, is upwards of $500 million statewide. So those costs are being shifted to private payers. On top of that, of course, you'd have to add the losses associated with Medicaid. The state is an extraordinarily poor payer on Medicaid and pretty limited on eligibility, which affects uncompensated care. That number's growing. Both numbers are growing, unfortunately. And perhaps healthcare reform at the federal level will provide the incentives to get Virginia to start to narrow that gap and lessen that cost shift burden on employers. Virginia's rate of uninsurance is about 15% of the population is uninsured. That's been remarkably stable relative to other states that have seen big increases. That's as of last year, though, and I'm quite sure that number is going to go up this year. That is a distinguishing difference. The top tier states often have rates of uninsurance that are well under 10. It turns out, if you have a lot of people are uninsured who don't have regular access to the healthcare system, guess what? They don't get very effective healthcare. So that's why you see a lot of those southern states, the dark blue, they have higher. That's one of the reasons they have higher rates of uninsured. Thank you all.
Give Chris Bailey another round of applause. Thank you. Before we conclude for the day, I'd like to recognize the members and officers of the VBCH Board of Directors for the upcoming year. If you are here, please stand while I call your name. Eileen Ciccatelli, our president from the Virginia Business Coalition on Health. Ursula Butts, president-elect, Community Memorial Health Center. Michael Lundberg, secretary, Virginia Health Information. And Thelma Baker, treasurer from the Virginia Health Quality Center. And also our other board members, Dr. Siobhan Dunavant, Dr. Skip Walker, Doug Gray, Dr. Barbara Brown from VHHA, Dr. Tim Musselman from the Virginia Pharmacists Association, Dr. Ron Clark from VCU, Kendra Cooper from Riverside Health System, Kay Lewis from the Kaiser Foundation Health Plan, Michael Matthews from Med Virginia, Katie McCullough from CJW Medical Center, Jim Morford Dr. Chalmers Nunn from Centra, Dr. Karen Remley, Commissioner of Health, Carol Sale from Centera Healthcare, Abraham Segrist from UVA Medical Center, Dr. Christopher Stolley from Riverside Health System, and Karen Swisher from VCU. I'd also like to thank Laura Knowles, our staff person from Richmond Academy of Medicine, who is responsible for virtually everything that happened in this room today behind the scenes, and she did a great job, and I'd like to give her a round of applause. I'd also like to take a moment to thank Eileen Ciccatelli for volunteering to serve this year as the chair of our conference planning committee. Her and Laura were truly the brains and brawn behind this effort and did a fantastic job, and I'd like to call Eileen forward to just to receive this little token of our appreciation. She's done an excellent job putting together a very impressive program. Took a tremendous amount of work.
Thank you. Thank you very much. And Joe, I want to thank you. Joe, I want to thank you as president-elect of VBCH, and now coming in as president, for your leadership with VBCH and joining the Business Coalition with VBCH. I think was, you were very receptive to that. We've had 2 great years of partnership, and hopefully we can continue that. And I salute you, Joe, and I understand I have a small gift for you, and I'm happy to have worked with you for the last 2 years, and we'll be working some more together, right? Thanks. And I also want, and I wanted to thank Rob Locke as our chair of the Virginia Business Coalition on Health Summit Committee. Rob, would you like to come up to the podium? I have a small gift for you to thank you for your energy and the input you had into the entire program. Thank you very much. And then Bob Kramer would like to come up and just mention the credits of our Virginia Business Coalition on Health Board of Directors and members of the board, of the coalition.
There's that many of them left here. But I did want to recognize the board members. Vicki Lucenta, who you met, I think Vicki had to leave, but she was on that last panel. Jennifer Jones at Centera Healthcare. You can see out there. Of course, Bob Locke, Richard Keeley of Mercer, Dr. Andrew Ballas of Old Dominion University College of Health Sciences, Larry Boyles of the Riverside Health System, and Courtney Miller, William Mullins, and Linda Matkins. I think Linda is here, of Virginia Beach Schools. I also like to thank, of course, Barbara Wallace, our CEO, our Vice President, Linda, Eileen Ciccatelli, and Nancy Mazzi, our Administrative Assistant. Thank you very much.
Thank you very much for your time and attention today, for sticking to the very end. And we are adjourned, and have a safe trip home. Thank you very much.